Dr. Schattendorf, I'd like to ask you specifically about one very interesting abstract with a combination of neoadjuvant TVEC and the immunotherapy. Very quickly, if you could comment on, so it was a randomized trial.
Yeah, it was actually a large randomized trial, one of the largest neoadjuvant trials so far, with 150 patients randomized in 2 arms. TVEC in front, and then surgery in the first arm, and the control arm was surgery right away. And I think what was seen and at the presentation at ASCO shown is that there are several benefits in favor of the combination of the in-front TVEC therapy with improved rates of R0 resections, which were in favor of the combination. R1 resection were also better, 31% of the patients versus 51% of the patients. So resectability of the disease was much better. And that also translated into a relapse-free survival rate at 1 year, which was 22% to 29%. So it's already after 1 year a clear benefit. The only small caveat I would see in that setting is that roughly 25% of the patients with a TVEC in front patients have not made it to the planned surgery. And in the control arm, 7% of the patients did not undergo planned surgery. So I think that's a concern with all neoadjuvant approaches. Are you reaching the standard of care at the end?
And I know, just before I go to Dr. Ray, I think that goes back to the point of what are the correct endpoints for such trials, a challenge. So
because
would you like to comment maybe on...
Yes, because we have to realize that we are away from the usual objective of neoadjuvant treatment with chemotherapy or even BRAF/MEK, which really the goal was to decrease the size and to make the tumor accessible to surgery. Now we know that the main goal is to induce a distant immune response, and maybe finally not being able to do the surgery, maybe it's not going to be that bad at the end.
I completely agree with you, Caroline, because I think the concept of neoadjuvant therapy, which was born in the field of breast cancer, for example, had a completely different objective than what we are doing now with neoadjuvant approaches in melanoma. And I think, not to confuse the community, I think it's important to clarify the different endpoints and aims of such a treatment, and that possibly even missing a surgery might not be a disadvantage for the patient. I think that needs to be tested in the further clinical trials.
And also the complete pathological response, which is absolutely not correlated to overall survival in breast or in pancreas, might be with immunotherapy. We have the hope that it will be.
Yeah, looking at these meta-analysis presented by Alex Menzies on more than 180 patients collected globally, 2/3 of these patients had neoadjuvant checkpoint blockade and 1/3 had targeted therapy. The rate of complete responses, pathological responses, was quite comparable. But if you look at the relapse-free survival after 1 year, for targeted therapy it was just 65%. For checkpoint blockade it was 20% better. So I think that is clearly emphasizing what you said.
Yeah, and let's not forget that the very best data set of all those data sets in there in the meta-analysis is the Amsterdam study, which shows 2 things: that neoadjuvant with just anti-PD-1 is inferior to neoadjuvant with anti-PD-1 plus anti-CTLA-4, and that you actually have a biomarker there because it's the magnitude and the variety of T-cell clones that are being induced by the combination of anti-PD-1 and anti-CTLA-4. It gives the highest biomarker output, it gives the highest pathologic complete responses, and there's not a single patient who has relapsed after surgery, and all patients made it to surgery. This is now the golden standard to look up to and to compare all other data to, and all other data are inferior to this. So we should not do as if there is not a superior data set. There is a superior data set out there that will define what is going to happen in the future. Because on top of that, they have a locally advanced rectal cancer program for MSI rectal cancers. The first 8 patients, 7 out of 8 have a pathologic complete response. And what do? You don't even operate them anymore. You just follow them by rectoscopy and by MRI, and no more rectal amputations for MSI colorectal cancers. I mean, this is a true revolution. So let's not underestimate what the data is right now telling us. This is the superior approach that we need to work with and that we need to use as a comparator to any other development.
Very interesting, but let's emphasize it's still experimental. We don't have any approved neoadjuvant approaches, but very
It
good
will
data
be,
coming out.
it
but
will be
hopefully
approved, believe me.
Yeah,
It
hope
will
so,
be
hope
approved.
so. Very
Yeah.
good.